get a booster with Pfizer? I was a little unclear on that. Thank you.
Yeah, this is Janet Woodcock. Let me start, and just to make sure everyone is clear on this. Right now, if you got J&J, you get a booster after 2 months. If you got Pfizer as your primary series, you can get a booster at 5 months or beyond. If you got Moderna, you could get a booster at 6 months or beyond of whatever you decide to get a booster of. Dr. Marks, further comment?
No, that's exactly right. So for right now, today's action pertains to the Pfizer vaccine. The boosters for Moderna remain unchanged at the moment at 6 months.
Thank you. Operator will take the next question.
Next question comes from Emily Cox. Your line is open.
Hi. Given that vaccinated children, do you expect booster shots in 12 to 15-year-olds to have any benefit to those kids as far as reducing transmission? Thanks.
I'll ask Dr. Marks to respond.
So, the question of reducing transmission versus reducing disease is always an interesting one. The hope is that by reducing the number of 12 to 15-year-olds who get COVID-19 of any form, that we will help reduce the transmission of COVID-19. But the direct benefit here that to the 12 to 15-year-olds of a booster is that it will hopefully prevent COVID-19 in its various forms. In particularly, we're most interested in making sure that we prevent serious outcomes such as hospitalization and deaths, which, granted, though uncommon in 12 to 15-year-olds, can occur.
Great. Thank you. Operator will take the next question.
Okay. Cheyenne, your line is open.
Hi. Thank you for taking my question. I wonder, should parents of kids have any concerns about risks of myocarditis or pericarditis, as we've discussed in the past when we're looking at vaccines for adolescents? And in general, now that we're going forward with boosters for this age group, where does the FDA stand on whether or not there will be an Omicron-specific vaccine needed?
So 2 different questions. This is Janet Woodcock. So the data on myocarditis with the 3rd dose with this booster in adolescents is in our information that we posted. We expect that would be extremely rare in the 3rd dose, and we have the real-world evidence from the Israeli experience to help us with that analysis. And I'll leave the second question to Dr. Marks, I think.
Thanks. So the issue of an Omicron-specific vaccine is one we're just going to have to sort out. The manufacturers are all working on the possibility of an Omicron-specific vaccine, but it's not clear that we'll need to roll one out because we don't know yet whether Omicron will take hold as the dominant variant over time. It could be that we'll have a very quick wave of Omicron, and then something else will be left behind it. So until we understand that, we can't say with certainty what we will do with a variant vaccine. But that being said, we are preparing for the possibility that we could have an Omicron-specific variant vaccine. In other words, we don't know yet that it'll have to be deployed, but we'll be ready in case it does need to be deployed.
Right, and this is Janet Woodcock. The last thing we want to do is just be going through and getting new vaccines and this and that. If the current boosters look like they will, really do the job against Omicron, as Dr. Marks said, then we also have to consider that we might have additional variants, but we will be ready, whatever, to switch if needed.
Okay. Thank you. Operator will take the next question.
Lauren Gardner, your line is open.
Hi, thanks for taking my question. Safety has long been the concern when vaccinating children and teens, especially with the myocarditis signal identified last year. So how can you say that the lack of a signal in the Israeli study, which was 6,300 young teens, how is that enough to extrapolate and say that giving a booster to 12 to 15-year-olds here in the United States, that the benefits outweigh the risks, especially when the EUA itself says the booster, quote, may be effective? And how are you able to make this decision given the newness of the data? Specifically, why were the independent advisors not convened to give a recommendation before this announcement?
Okay, well, FDA performed a benefit risk looking at the current epidemiology of the virus in this age group, and also looked at the immunology as well as the real world experience. And Dr. Marsh can talk more about that.
Yeah, so let me just, let me unpack two questions there. One question is about why we think the benefits outweigh the risks in the 12 to 17-year-old age range. And the other is why didn't we consult or 12 to 15-year-old age range, and why didn't we consult our advisors? So the 12 to 15-year-olds, we had done benefit risk analyses for the second dose, where we know that the second dose of the vaccine given to 12 to 15-year-olds has a higher risk of myocarditis by probably 2 to 3 times higher risk of myocarditis than a third dose. And that comes from data that came out of Israel and data that came out of prior studies. So the idea here is that we are willing to use data to look at it closely and make inferences in this case. And the inference here is that the risk of myocarditis with third doses in the 12 to 15-year age range is likely to be quite acceptable given the potential benefits. Remember that the myocarditis that occurs with the Pfizer and Moderna vaccines is relatively mild. It's generally been a median hospitalization of 1 day. Treatments have generally been with things like non-steroidal anti-inflammatory drugs or acetaminophen. And in a series that was published by CDC, really we don't see, we're not seeing long-lasting effects. That's not to say that we don't care about this and that it's not important, but what it's to say is that in the setting of a tremendous number of Omicron and Delta cases in this country, the potential benefits of getting vaccinated in this age range outweigh that risk. And that risk-benefit calculation is based for a second dose, but we know that for the third dose, the risk is probably about a third based on data. So we can look at that risk-benefit and still feel comfortable. And the reason for not taking it to our advisory group, we use our discretion when we bring things to advisory group. When we feel like there is some question that is likely to actually need public discussion, we do this. And we sometimes consult our advisory committee chairs to decide what questions to bring to committee. This one was one where in the setting of a wave in which, for instance, yesterday there were 400,000 plus new cases reported in the United States over the past days or two, that it made sense to try to move as quickly as we possibly could.
Thank you. Operator will take the next question.
Elizabeth Weiss, your line is open.
Topic, but amidst all the calls for boosting of Moderna and Pfizer folks, I'm hearing from some people who got Johnson & Johnson vaccine who self-boosted, perhaps before the authorization went through in October, and are now feeling like, so they've got one Johnson & Johnson, and then perhaps a Pfizer at some point, and now they're many months out, and they're wanting a third dose, but when they... Any sense of when we might have such boosting, at least data, to know whether it's necessary and helpful? Thanks.
Dr. Marks.
Yeah, thanks. It's a very good question, and it's probably going to be in the coming weeks to months that we will be able to sort through which of the combinations here is optimal and where one might want to get an additional booster. You might be aware there was a mix and match study that was done, which showed that in some cases, the mixing and matching of, for instance, an adenoviral vector vaccine and an mRNA vaccine seemed to give very good immune response, but we need to see how that looks over time. Those data are becoming available from those who receive such combinations in Europe and elsewhere. And as we get those data, we'll analyze them and then potentially make recommendations.
Thank you. Operator, we'll take the next question.
Lauren McKinley, your line is open.
Doing this. Happy New Year. You said in the statement that you're keeping a close eye on the 5 to 11 group in terms of boosters. Do you have any idea when you might have an idea on when that group might need boosters? And also, could you give us an update on the younger kids, the below 5-year-olds?
Yeah, there's probably not a lot we can say about pending actions. Dr. Marks?
So for the 5 to 11-year-olds, we'll be following the immunity, their immunity after their second doses, and we'll make a determination based on what we're seeing about the appropriate timing of the booster dose. As it turns out, right now, most of them are still only have received their primary vaccinations in the relatively recent past. And in fact, I'm going to have to say that we should be trying to get as many of those individuals vaccinated, because last I looked, only about 25% of eligible 5 to 11-year-olds had been vaccinated. So would be great to get a larger percentage of those kids vaccinated, and then we'll see how many months afterwards we need to get them boosted. As for the 0 to 5 year age range, although we can't talk about our actions, we can say that we certainly understand that there is a pressing need in that age range, that we understand the hospitalizations that may be occurring in that age range, and we will move with appropriate speed with the appropriate data in hand.
Thank you. Operator, we'll take the next question.
Terrell, your line is open.
Well, thank you. I just wanted to follow up on the decision to shorten the time between second dose and booster for Pfizer and not Moderna. Is that based on a faster waning seen with the Pfizer vaccine in protection, coupled with more data on the safety and efficacy of boosting them from Israel and elsewhere? Or is it just that there aren't similar data on the safety and efficacy of boosting earlier with Moderna?
Good question. Yeah, Dr. Marks, you want to address that?
Yeah, happy to do that. So as in the past, we have always done things on the basis of data, and the data that we had in hand first was data from that was brought to our attention by Pfizer that had to do with the 5-month interval. I can point you to a publication in the New England Journal on December 23rd in 4.7 million Israelis, where the boosting interval in the population in that study was 5 months. So they had those data, and we will obviously be receptive to data that are submitted to us from Moderna, and we'll take action on those data with all due speed. Again, given that we are in the middle of this a very, very significant wave of the pandemic. I have to say that one of the things we're talking a lot about boosters right now, but it's not too late for those who have not gotten a vaccine at all to get a vaccine. As much as we're trying to prevent any type of COVID-19, we know from our previous studies that even a single dose of the vaccine, and preferably 2 doses, but even a single dose can help prevent the worst outcomes from COVID-19, including hospitalization and death. So hopefully this will be not just a call for people to go get their booster shot, but for the tens of millions of Americans who have not had a chance to consider the implications of not getting vaccinated fully. It's now another chance to go, and it's not too late to start to get vaccinated.
Right.
Thank you. Operator, we'll take the next question.
Your line is open.
The call. I wanted to follow up on the myocarditis risk question. It seems like from that we should have a lot more data by now than we've seen from the experience of giving boosters to 16 plus and from the second doses in this age group. Can you talk a little more about what we know about the myocarditis risk compared to the last presentations that were made at CDC and how that may have impacted your decision here? I know you think the risk-benefit is bigger regardless, but it seems like having a finer point on that might be helpful in terms of getting vaccine uptake.
Okay, Dr. Marks, you want to talk about that?
I'm happy to take that one. Yeah. Right. So, what we do know now is that I will tell you what we know and then kind of a little bit of what we speculate. So what we know is that it appears that the myocarditis risk seems to peak in the 16 to 17 year age range. It's primarily something that's affecting males. There is a tail of this that continues to go up into males up to age 30, but the peak seems to be around age 16 to 17. The data that keeps coming in appears to be consistent that it is a relatively uncommon side effect. The really overwhelming majority of these cases, 98%, have been mild with this one-day median hospitalization overall, and the rate is somewhere on the order of 1 in 10,000 in this male age group of the 16 to 30 year range. And it could be a little bit lower, it could be a little higher. It depends on exactly how you use the case definitions. The speculation is that I will make, and this is speculation, but the thought here is that there is probably some interaction between the timing between these first 2 doses being somewhat shorter and the androgenic steroids that are present in males and that tend to peak in puberty that may be leading to this having its peak at that time. That's, again, speculation, but it may also be why we believe that the risk is somewhat lower in the 12 to 15-year-olds, and from the surveillance data that we have to date in that age range, it appears to be confirming that. But we will continue to monitor this very closely because obviously this is something that we want to get a handle on. For third doses, the way this is consistent is it does appear that the risk with third doses appears to be lower than after that second dose. So it does seem to be something about the time interval there that is affecting things as well.
Thank you. Operator, we'll take the next question.
Mr. Sullivan, your line is open.
Hi, thanks. I wanted to ask about the the time after a second dose until you get your booster. The United Kingdom, for example, is doing just 3 months. So I wonder, why not do less than 5 months for Pfizer? Why not do 3 months, for example, like some other countries have done?
Well, this is Janet Woodcock. We do our actions based on data that we have, and we have data down to 5 months that we can reliably, project, what's going to happen in the larger population. I think hopefully we will get real world data from the UK, and we can see what that shows. But as Dr. Marks just said, some of the benefit risk considerations may mitigate against giving an earlier boost, and we don't know that until we get the data. So I think it's right now the action we're taking is based on the information that we have, and we do know that the waning has occurred by 5 months. So basically, it's the fact that we have information. And I would ask that if people are asking questions, would you please state your affiliation too, please? Thank you.
Thank you. Operator, we have time for one last question.
Okay. Murphy, your line is open.
Thank you. I'm with the Associated Press. Just following up on the myocarditis risk. Did I hear you correctly earlier when you said that the risk in teens with the third dose is about 1/3 of the risk after the second dose? Did I hear that right?
Dr. Marks?
Yeah, so that's correct. That's what we believe, that with a third dose, we have done, based on our surveillance data, and comparing this, it's about 1/3.
Thank you.
Thank you. This concludes today's FDA press conference. A replay will be available on the FDA's YouTube page. Thank you and have a great day.
Thanks.